Welcome to late adulthood, where you'll be learning about the cognitive changes that take place in this stage of life. Before we begin, think to yourself, what memory changes do you think are normal or typical of the aging process? And what do you think is not typical? How would you know if someone you love has the symptoms of Alzheimer's or if what they're experiencing is just typical aging? In this video, you'll learn about this and more as we explore the many important topics related to cognition in late adulthood. Let's now explore the cognitive changes that are experienced in late adulthood. After this section and after having read your book and watched some of the associated videos that are on D2L, you should be able to describe how memory changes for people in late adulthood. You should also be able to describe the theories for why memory changes occur. You should be able to describe how cognitive losses in late adulthood are exaggerated. And you should be able to explain the pragmatics and the mechanics of intelligence. You should be able to define what a neurocognitive disorder is and explain Alzheimer's disease and other neurocognitive disorders. You should also be able to describe work and retirement in late adulthood and explain how those in late adulthood use strategies to compensate for losses. Let's first take a look at the changes in working memory. Before we do this, I want you to reflect on in your mind what you've learned about memory. Earlier in this semester, you learned about what was called sensory memory. You learned about short-term memory and working memory, and then you also learned about long-term memory. So working memory has two interrelated functions. First, it temporarily stores information so that we can use it consciously. It's like a mental sketch pad or workspace. And then it also processes information that's currently in our conscious mind by using integrative reasoning and mental calculations and drawing inferences. So with working memory, its capacity for storage and processing in late adulthood produces noticeable decreases, more than any other stage of development. This is the part of our central executive that is most negatively affected by age. And this then can result in increased difficulty in allocating cognitive resources, difficulty monitoring the effectiveness of cognitive strategies, and learning new types of tasks when we're learning two or more at the same time. So what happens with long-term memory as we get older? Well, episodic memory shows greater age-related declines than semantic memory. Episodic memory is your memory for basic events, life events, things you've experienced, and semantic memory is your memory for facts and general knowledge. So an example of episodic memory would be remembering your high school graduation or remembering Thanksgiving dinner last year. Whereas semantic memory might involve, for example, knowing that France is a country located in Europe or having some general knowledge about US history. So semantic memory, memory for general knowledge, episodic memory for life events. And so episodic shows the greatest age-related declines. And older adults outperform younger adults on semantic tasks, but they seem to have more of what are called tip of the tongue events. And so this means that when they're trying to say something, it's like you've said before to yourself, oh, it's on the tip of my tongue, I just can't remember, or I can't get it out. So there's more of that sort of event where they feel like they're remembering and they feel like they're going to be able to say what they're wanting to say, but they just can't. It's just right there on the tip of their tongue. And then implicit or procedural memory shows the fewest declines with age. So procedural memory involves automatic processing, and this would be your memory for doing things like riding a bike, for, of course, walking, for tying your shoes. So any sort of procedure. That's what this type of memory is, and it shows it really shows few declines with age. There are some additional memory changes in late adulthood. So let's take a look at prospective memory. There are two types of prospective memories, and prospective memory is your ability to remember the things that you need to do in the future. And so we have time-based memory, which is remembering to do something at a future time, and event-based, which is remembering to do something when a certain event occurs. So an example of an event-based memory might be driving past the local library cues the remembrance of the need to return an overdue book. And there are more age-related declines for time-based prospective memory. So cues seem to be helpful in triggering memories, especially this is going to be of especially greater or greatest importance in late adulthood. There are also some additional differences in memory as we get older and compare ourselves to people who are younger. So we have two different types of tasks that we use to remember. We use recall, which is where we try to remember something without any cues that are present, and then we have recognition. And recognition involves using cues. So just to give you an example, if you're taking an exam and you're asked an essay question and you have no clues that are present within the essay question, this would be an example of a recall task, whereas a multiple choice question is an example of a recognition task because you have those cues that are present. So recognition tasks are easier, as you can imagine, because they require less cognitive energy. And older and younger adults perform similarly on recognition, but older adults do show declines in recall memory. It seems, though, that there is an advantage that people who are older have. Older adults can use knowledge or experience to compensate so that they may seem that they are able to remember things, but it may be that they're not necessarily remembering as well as they used to. They may be compensating for what they're trying to recall by incorporating existing knowledge that they have because they've had more life experiences, more learning likely that's taken place throughout their lifespan that's going to help them to fill in those gaps or spaces. As one gets older, there are also changes in attention, and these changes are affected by changes in sensory functioning and the speed of information processing. Older adults are less able to selectively focus and ignore distractors. So you might think, for example, of a parent or grandparent when you're talking with them and perhaps someone comes in the room and interrupts. That older adult is also going to have more difficulty shifting their attention to that new stimulus or that new person coming in than you would as a younger person. And that's because older adults have greater difficulty in shifting their attention. Perhaps many of you have found yourself seeking out a parent or a grandparent or someone who's older in your life to help you to work through some of the problems that you're experiencing. And you found that this is a very helpful strategy for you to use. And it's helpful often because older adults seem to use more effective strategies than younger adults to solve social and emotional problems. And they have more efficient strategies and expertise to compensate then for cognitive decline. To me, this relates to wisdom. And we're going to be exploring wisdom in a little while. But when I think about wisdom, I think about being able to use life experiences to help us to solve problems and to do so in a very rational way, but in a way that is also thoughtful of other people's needs and feelings. Now, that's just one part of wisdom, and that's part of how I view wisdom. And I think that an ability to solve social and emotional problems would seem to be an important part of being wise. I also want to mention, too, that performance on tasks that require processing non-meaningful information quickly declines with age. And each of these may not translate into real-world problem solving. As one gets older, there are also some differences that one experiences in processing speed. Processing speed theory suggests that a slowing nervous system affects the ability to process information. I think it's so important to note, though, that when speed is not a factor, there are few age-related differences. So this tells us about the importance of giving older people additional time to think through problems. They are just as effective and if not more effective, as we looked at the ability to solve social and emotional problems. They just may need a little bit of extra time. There's also a theory called inhibition theory, and this may in part help to explain a reduction in processing speed. So inhibition theory suggests that older adults have difficulty suppressing irrelevant information. This may then affect the speed at which someone is able to solve a problem. If you have irrelevant information coming into play as you're trying to solve a problem, then it may make it more difficult for you to solve that problem as quickly as someone who doesn't have that irrelevant information interfering. So what explains the reasons for these age-related cognitive differences? Well, let's first ask ourselves, are these laboratory tasks that older adults are being asked to engage in these studies actually meaningful? Often they're not meaningful. And is it the lack of meaningfulness that is causing the differences and not general age-related decline? So it may be that if we were to ask older adults to engage in much more personally meaningful tasks, we may see fewer differences or less cognitive decline. Also, we have to ask ourselves about the potential over-reliance on cross-sectional research. When we think about cross-sectional research, we need to remember first what it is. When we do cross-sectional research, we're taking different segments of a group of people based on their age. And so we might, for example, compare 10-year-olds to 20-year-olds to 30-year-olds to 40-year-olds and so forth. And there are other ways to do cross-sectional research. And if we're looking at cognitive decline in late adulthood, we might compare people in middle adulthood to people in late adulthood. And we might divide the ages into smaller units or smaller groups. So when we think about this, when we think about cross-sectional research, we need to remember that we're comparing people at one moment in time. And so when you think about, for example, your grandmother or your great-grandmother, so let's think about a grandmother that you have who is 75 years old. That grandmother has had unique life experiences that are very different from, say, a 55-year-old or a 35-year-old. And those experiences aren't just due to her unique personality or something about her unique upbringing, but they're also due to some overall differences in terms of time. So think about people who are 35 today and how different the world is today for 35-year-olds versus how it was for 75-year-olds when they were 35. So if we compare different age groups at the exact same time, it may not be that we see differences that are solely attributed to age. It may be that these differences can also be explained by experiences that are unique to each of these different age groups because of the time within which they grew up or the time within which they have lived. Also, another important factor to think about is lack of practice. So it may be that in these tasks where we're seeing a reduction in cognitive decline in certain areas, that if the participants were given opportunities to practice more, we might not see such differences in cognition or overall in memory and attention speed when we compare older people to people in middle adulthood or in early adulthood. And then it may also be that some of the differences that we see that emerge in late adulthood may not be due to specifically directly tied to cognition, but more tied to sensory deficits. We know that there are sensory changes in late adulthood. So is it that those changes in vision, in hearing, for example, etc., that those changes may be contributing to some of the differences that are seen in older adults that are related to cognition? When we think about intelligence, intelligence is something that is much more complex than just one particular concept. So when we think about intelligence, we often think about things like visual spatial skills, mathematical skills, skills related to logic and verbal skills. But actually, there's a lot more to intelligence than that. And so we can see that there are some changes that are experienced in late adulthood related to very specific aspects of intelligence. So first, what we see is that basic information processing is dependent on brain functioning, and it does tend to decline with age. And this is what we would refer to as fluid intelligence. And this type of intelligence is a basic intelligence that uses logical thinking and problem solving that enables quick and thorough learning. And so there is some decline in this area with age. We also, when we think about intelligence, need to think about the pragmatics of intelligence. And this would be our cultural exposure to facts and procedures. And this is maintained with age. And older adults may be able to compensate for declines in this area in other ways, in other areas. This type of intelligence is similar to what you learned about earlier in the semester, which is called crystallized intelligence. So it's similar to crystallized intelligence. And crystallized intelligence, if you'll remember, consists of accumulated learning, like vocabulary and general information. So it seems that crystallized intelligence is much better maintained than fluid intelligence. Let's take a look at wisdom. Wisdom is the ability to use the accumulated practical knowledge for good judgment and decision making. There's certainly been a lot written about wisdom, and even still, the concept of wisdom is fairly elusive. And when we look at what wisdom is, wisdom depends upon our ability to make good judgments, but it also depends upon our abilities to appreciate the needs and the viewpoints of others. And this is dependent on experience and personality, not just age. So the association of wisdom with growing older equates accumulated life experience with getting wiser, but not all people who get older actually become wise. As you reflect on Erik Erikson, you'll remember you learned about the stage of generativity versus stagnation. And we can think about stagnation as being equated with self-absorption. Now, as we move into late adulthood, if someone continues to be self-absorbed and not think about giving to the next generation and leaving that legacy in the ways that Erikson suggested by, for example, being a mentor or volunteering, sharing with one's children their knowledge and their life experiences, being a teacher, and there are multiple ways that we can be generative. If we're not generative, I would ask you to ask yourself, do you think that one can really be wise or very wise? Do you think that people who are generative would be wiser? When we think about wisdom, I think we need to also think about how important it is for a person to be self-reflective, to be open, to be informed, to be engaged with the world, to have this ability to trust others, an ability to share with others, an ability to really reflect upon one's own life and have that sense of intrapersonal intelligence. So wisdom is very complex, and certainly some older adults are much wiser than others, and you may know young people who you may say are wise beyond their years. Often, though, they may not have all of the life experiences that come with that full development of wisdom, but still they may have that ability to use good judgment and decision making. So young people can certainly be wise beyond their years, but I do think it's important to remember that age does enter the equation in part because wisdom is associated with empathy and compassion for our fellow human beings based on having experienced similar events or feelings that, ourselves. And the older that we get, also, the less self-motivated we tend to be and the more available to others we can be. So perhaps later in life, we are less socially and biologically distracted by our own impulses and our own emotions. If we reflect on Erik Erikson, we have already resolved those earlier developmental tasks, and we have shed that need to make something of ourselves. Instead, we have a need to share with others. Let's now take a look at neurocognitive disorders. These disorders used to be called dementia, and major neurocognitive disorder is a significant decline in one or more cognitive areas. So we would see perhaps a significant decline in memory or thinking, and this decline is going to be interfering with everyday life. Major neurocognitive disorder is actually very common with more than 3 million cases per year in the United States. And there are treatments that can help to manage neurocognitive disorder, but it depends upon what is causing the decline in these different cognitive areas. Often when someone has a decline in memory or a decline in thinking, imaging can be done to determine if there have been brain changes, and that can help the patient and their doctor to better understand what's contributing to the decline in their cognitive functioning. Also, major neurocognitive disorder is not only limited to late adulthood, but it's much more likely to happen in late adulthood. And so it's overall common for people who are 60, 65 and older. It's also more common in females, and if you have a family history of having a major neurocognitive disorder, then you're more likely to have this as well. Some of the specific symptoms of major neurocognitive disorder are cognitive and sensory changes, but there also can be psychological changes. So some of the cognitive and sensory changes can be, as I mentioned a moment ago, memory changes or memory loss. And this tends to initially be noticed by people who are very close to the individual. And then eventually it becomes more apparent to other people. There may also be some difficulty in communication, maybe some difficulty finding the right words to communicate, some difficulty in organizing, planning, and reasoning or solving problems, some confusion and some disorientation. You might also see a difficulty with coordination and motor functions. You might also see a loss or a reduction of visual perception. And you might see some changes in taste and smell. Some of the psychological changes that can come with major neurocognitive disorder can be overall changes in personality and behavior, depression, anxiety, hallucinations, mood swings, agitation, and apathy. Apathy meaning the person doesn't really care much about what's going on around them or what they're experiencing themselves. Major neurocognitive disorder can be caused by many different things that are going on within a person's brain and or body. And the first one we tend to think of is Alzheimer's disease. And so Alzheimer's disease is one explanation for major neurocognitive disorder. Also, there can be damage to blood vessels in the brain, accumulation of clumps of protein in the brain. Also, someone might have genetic disorders like Huntington's disease. The person might also have Parkinson's disease, which we've looked at earlier. The person may have a traumatic brain injury or perhaps a repetitive brain injury if we think about people who've played professional sports like boxers and football players. A person may have had infections that caused high fever that then affected their brain. A person might also have issues with medication that they're taking. Some medications can cause some significant changes in cognition. An older person may also have some vitamin deficiencies. We talked about how changes in taste and smell can affect a person's eating behavior. So an older person may not be eating as much or what they need to be eating. And this then can result in vitamin deficiencies, which then can affect cognition. A person may be abusing alcohol. There might be a brain tumor or cancer, or there might be enlarged structures of the brain. Overall, though, Alzheimer's disease accounts for the majority of cases of neurocognitive disorders. When a person has only a slight decline in the functions that we think of as being associated with major neurocognitive disorders, so again, maybe some slight declines in the ability to plan, a slighter decline in the ability to make decision, a slighter decline in focusing on tasks and being able to remember the names of objects and people, a slight decline in struggling to perform daily tasks, and a slight decline in speaking or behaving in ways that are socially accepted. So you might see that person behaving in ways that are somewhat not socially accepted. So again, when the decline in one of these functions is severe, it's considered major. When it's mild, it's considered a minor neurocognitive disorder. And where an individual falls on the spectrum of neurocognitive impairment is often determined by the degree to which that condition affects their level of independence. For both mild and major neurocognitive disorders, though, the decline is typically enough to attract the attention of loved ones or their healthcare providers. And also for many of these causes of neurocognitive disorders, whether they be major or minor, they can be confirmed through testing. As I'd mentioned, the most common type of neurocognitive disorder is Alzheimer's disease. And this is a progressive disease that begins with mild memory loss that possibly leads to the loss of the ability to carry on a conversation and respond to the environment. This disease involves parts of the brain that control thought, memory, and language. And as many of you know, it can seriously affect a person's ability to carry out daily activities. Alzheimer's disease is thought to be caused by both genetic and environmental factors. For most people with Alzheimer's disease, unless they have what's called early onset Alzheimer's disease, it's a slowly progressing, irreversible neurodegenerative brain disease that has a long phase, sometimes up to 20 years, and the average duration is around 8 to 10 years. The progression of Alzheimer's disease is accompanied by changes in the brain that really serve as biomarkers of the disease. In your textbook, figure 929 shows you the timeline of Alzheimer's disease, where first an individual experiences early brain changes, and then there's a subtle decline in thinking, and then a progression to memory changes and confusion, and then a progression to an inability to bathe, dress, or eat without help, and then a progression to the loss of the ability to communicate and recognize loved ones. The more milder symptoms of Alzheimer's disease tend to last around 7 to 9 years, although this can vary from individual to individual. And so when Alzheimer's disease is fairly mild, the symptoms are short-term memory loss and then some reading problems, perhaps some difficulty recognizing objects, and a reduction in the ability to recognize where one is and to have a sense of direction. After a person has had the milder symptoms of Alzheimer's disease, they then progress into a more moderate form of the disease. And as this progression happens, you see continued changes in the brain. And here we're going to see about 2 years of these moderate symptoms of poor judgment, some difficulties with attention, and some impulsivity. And then we move into severe Alzheimer's disease. And the progression here, or the time frame here, is around 3 years. It's at this where the individual loses their ability to respond to their environment, where they have a lot of difficulty carrying on a conversation and eventually difficulty controlling their movement. They might still say words or phrases, but communicating becomes much more difficult. And this includes communicating feelings of pain, which can be a big challenge for those who are caring for people with Alzheimer's disease. People in the later stages of Alzheimer's disease, or this late stage, are very vulnerable to infections and pneumonia, and they may not be able to tell others that they're not feeling well. And so it's so important that people who are in the late stage of Alzheimer's are closely monitored by healthcare professionals. And this is generally where you've seen family members who have had their loved one go into a facility to be taken care of, because it's come to a point where even home health can be very difficult, because the home health aide may not be available to take care of that person throughout the day and throughout the night. It may be that it seems because of the individual's medical needs, they can't have those needs met at home. Even if they're able to have care 24 hours a day, let's say, having those medical needs met may not be a possibility at home. And so this then is a time where an individual is very likely not going to be able to live at home or be cared for at home. It's believed that Alzheimer's disease is based on the buildup of two proteins in the brain. And some of you have heard of these proteins before, amyloid beta and tau. And these are thought to be caused by advanced age or genetic factors. One of the markers or hallmarks of Alzheimer's disease is the abnormal accumulation of amyloid beta. And this is due to an imbalance in production and inadequate clearance in the brain. There's some evidence that these aggregated forms, or these plaques, these amyloid beta plaques, may be toxic to nerve cells. And in people with Alzheimer's disease, the presence of amyloid beta is thought to trigger a pathological cascade that might promote the abnormal activity of tau proteins. And then this leads to the formation of what you may have also heard of, which are called neurofibrillary tangles within neurons. These neurofibrillary tangles then disrupt the neuronal transport system, and nutrients and oxygen can't get to the neurons and they die. Figure 930 in your textbook shows what typical neurons look like and what neurons look like in an Alzheimer's disease patient. And you'll note that in the image with the Alzheimer's disease patient, you'll note significant differences. You'll see the neurofibrillary tangles as well as the amyloid plaques. Another type of neurocognitive disorder is vascular neurocognitive disorder. And this is a decline in thinking skills that are caused by conditions that block or reduce blood flow to different parts of the brain, which then deprives them of oxygen and nutrients. This generally affects one part of the brain and not all, and personality is often not affected. Often with this type of disorder, there's more of an abrupt onset, which is different from what we would see typically with Alzheimer's disease. Some of the risk factors for developing vascular neurocognitive disorder are smoking, diabetes, heart disease, hypertension, and a history of strokes. So ultimately, any condition that damages blood vessels anywhere in the body can cause brain changes that are linked to vascular dementia. I also think it's important to note that just like Alzheimer's disease, advancing age is also a major risk factor. Another type of neurocognitive disorder is neurocognitive disorder with Lewy bodies. Lewy bodies are microscopic protein deposits in neurons, and these deposits affect chemicals in the brain, whose changes then can lead to problems with thinking, movement, behavior, and mood. And this is a common form of, or a common type of neurocognitive disorder. In the beginning, it can be difficult to accurately diagnose neurocognitive disorder with Lewy bodies, and this is because the symptoms, the early symptoms, can often be confused with the symptoms of other disorders like Alzheimer's disease or even psychiatric disorders like schizophrenia. This type of disorder is progressive, just like Alzheimer's disease is. And so this means that symptoms start slowly and then they worsen over time, just like we saw with Alzheimer's disease. The disease, neurocognitive disorder with Lewy bodies, it can average around 5 to 8 years from the time of diagnosis until the time that the person passes away. But the time span can range from 2 to 20 years. So 5 to 8 is simply an average. Also, it's important to note too that how quickly symptoms will develop and how they change does vary from person to person. And this variation depends on some different factors like the person's overall health, their age, and the severity of their symptoms. So as your textbook points out, a person with this disorder has impaired thinking, movement, behavior, and mood. And so overall, we might think of some very specific symptoms or signs. So for example, we might see some changes in concentration, changes in attention, changes in alertness. Also, we might see a person who has this disorder stare in space for long periods of time, or seem very tired, or sleep for several hours during the day, even though they've gotten enough sleep the night before. Their thoughts and their ideas may be disorganized and they might be illogical. The person might seem good one day and then the next day they seem to have gone downhill. And so there's fluctuations. The person who has this disorder, just like I mentioned a moment ago, may sometimes look like they have schizophrenia. And this is because this disorder can also cause visual hallucinations. This happens in up to 80% of people who have Lewy body dementia and can happen even early on. And these are typically really realistic hallucinations that can be very detailed, like images of children or animals or or loved ones. Some people who have Lewy body dementia will also have other types of hallucinations. They might hear things when no one is saying anything or when there's no sound, or they might smell things that are not present. And these are less common than the visual ones, but they do happen. And hallucinations don't always require treatment, but they can require treatment if they're very frightening and disruptive. And so a person may need to take medication that can help to suppress those hallucinations. The person might also have poor judgment, difficulty with language. They might be confused about time and place, some confusion about numbers, difficulty in problem solving and reasoning. So you can see how there's some overlap here with Alzheimer's disease for some of the symptoms, and then again some overlap with schizophrenia, which can help you to understand why there may be initially a misdiagnosis. So as I mentioned a moment ago, age is one of the biggest risk factors for developing Lewy body dementia. Most of the people who develop this disorder are over 50 years of age, and there hasn't yet been identified a very specific lifestyle factor that's proven to increase a person's risk of developing this neurocognitive disorder with Lewy bodies. I also want to point out, though, that there are some diseases and health conditions that are linked to a higher risk of this disorder. So conditions like Parkinson's disease and something called REM sleep behavior disorder. If you've not taken Introduction to Psychology, you may not know what that disorder is. REM sleep behavior disorder is where the signals that are normally shut down from to the motor cortex when we're sleeping during REM, they are actually not shut down, so that when a person is in a state of REM, they are acting out their dreams and literally acting them out. And you can imagine, because during REM, this is when we have our most vivid fantasy-like dreams, imagine then acting out those dreams and how disruptive and actually dangerous that could be. So it seems that that may be a risk factor. Also, genetics seem to be play some important role. It's not considered a genetic disease, but there are some genes that they've identified that have been associated with an increased risk of this. Important issues related to work include gender bias and cultural bias and racial bias, and those are ones that we commonly think of. But we also need to think about age bias, where we may think about someone differently because of their age. Now, we know that people who are younger may be viewed differently because of their age, just like people who are older may be viewed differently than others because of their age. In particular, older people face what we call ageism. And this is prejudice or discrimination on the grounds of a person's age. Your textbook cites that in 2015, 8.8 million adults 65 and over were employed or actively seeking employment. If we look at more recent data, in 2019, more than 20% of adults who were over 65 were either working or looking for work. This is a big change from the 1980s. If we go back to the 80s, we would see about 10% who were looking for work or who were employed. And this tells us something about demographic changes, and it also tells us something about the financial status or needs of the older population and the savings that they may or may not have, as well as the cost of living. We know how expensive medications can be. We know how wages have not kept up with the cost of living, so that when a person does retire, they may not have as much savings. And this may then force a person to feel like they need to work. Now, some individuals may also want to work as well. Older workers bring tremendous benefit to the workforce. They have lower absenteeism, and they're viewed as a greater investment in a company. Many older people are working because they see that it's meaningful and enjoyable. They may also be working because they need the income, and some are working not because they need the income, but because of the meaning that their work brings. And so they have a different view of work than perhaps people who are younger than them may have. We could think of wisdom too, that age can correspond with workplace wisdom. And older people are actually more likely to be successful entrepreneurs. We can reflect back on middle adulthood and go back to being in one's 40s. People who are over the age of 40 and up, they are 3 times more likely to create successful companies as a result of certain traits that they have: being patient, being collaborative, not feeling like they need to prove themselves. And this seems to be very helpful in creating their success. Older people tend to have better performance at jobs that require social skills, accumulated knowledge, and relevant experiences. And you can understand why as you reflect back on cognitive changes that happen as we move through late adulthood. So what have you learned about in this video? You learned about the memory changes that are experienced by those who are in late adulthood and some of the theories for why these changes happen. You also learned that cognitive losses in late adulthood are often exaggerated, and you learned about the pragmatics and mechanics of intelligence during this stage. You also learned about neurocognitive disorders, including Alzheimer's disease and others, and you learned about work and retirement in late adulthood. As always, after reading your textbook and after watching these videos, please don't hesitate to reach out to me with any questions that you have. I look forward to seeing each of you online.